we're here to discuss Miss Gracie Allen. I know everybody has talked to her today, and we've gathered some information. And there's a lot of issues that came out, I believe, based on information that we've gathered. So I know she's had multiple falls. She's isolated. I think maybe the best thing we could start with is maybe looking at some of those meds that she's on. So Sue, do you want to talk about what you found with the medication?
Sure. Let me start with something that I would call a prescription cascade. So I just see a lot of side effects that are being treated with other medications. Really, when I look at that, she is on the Prozac at a pretty high dose for her age at 40 milligrams. And that got switched from a citalopram, which when I looked up was about 10 milligrams. So not really kind of a step up as she got switched over to that. Prozac can cause quite a bit of nausea when you first start taking it, and she is having prolonged nausea. It definitely could be contributing to that. So that would be one thing I would think about.
She did mention that she had a 30-pound weight loss as well in the last 6 months.
Interesting.
Yeah.
And I'm not sure, it was hard to get how well that Prozac was working for her, but that would be something we should consider changing. They added the Raglan to treat the nausea, but Raglan can also contribute to restless leg syndrome. And I see here she's on 2 medications, which are really the same medications. She's on both Mirapex and Pramipexole, and when I questioned her, she's actually taking both of those. She was on the Pramipexole 1.5 milligrams, and then I think it was intended that the dose was increased to 3 milligrams, but she's taking both. So a lot with restless legs that may be too much for her, and actually one of the side effects of that medication can actually be some nausea as well. So she's now had promethazine, which wasn't on her med list, but she told us she was taking that now for nausea. And that can contribute to her constipation. So we have a lot of medications on board that may actually be contributing to other medications on board. So I think maybe starting with her depression and other ways that we may be able to treat that depression.
Okay.
So, I don't know if anybody has a depression screen that they did on her.
Yeah, so her depression screen, her PHQ-2 was actually a 12, which puts her into kind of the low, moderate kind of symptoms of depression. But I think on top of that, she acknowledges feeling, sad and depressed as well. So it sounds like, despite being on a pretty high dose of the Prozac, it's also not, treating very effectively the primary symptom of her depression.
Okay. What about her family? Did anybody find out any information about family? Is she living by?
Yeah, I think also contributing to that depression is her social isolation. There's a couple of things here. One, her husband died about a year ago, and she has not received any grief support for that. So that's definitely something I'm going to look into. I know that the hospices are providing a virtual bereavement support group, so I'm going to look into that for her. But also, her daughter lives 3 hours away and is also working as an RN in an emergency department. So she's very concerned, obviously, about visiting with her daughter with COVID concerns and such. But is comfortable in the Zoom format, like we did her assessment today. She was also very connected to her church, and she would attend once a month, but was a regular volunteer. So to address that, definitely to increase socialization, she was open to me reaching out to her minister to see if maybe some volunteers could come by the home. She was a little hesitant, a little embarrassed about that at first. Doesn't want to be a burden on anyone, but did say that she would be open to that. So I think that will help considerably if we can address the grief and loss and just really not having connection right now with family and friends.
Okay.
Go
ahead, Barb. Sorry.
I agree. I got the same impression from her. When I spoke with her, in addition to the falls, I think really one of her primary concerns was just pain management. And given the number of medications, I guess from an occupational therapy perspective, I'd like to approach it a little different way from a non-pharmacologic perspective. And she has limited range of motion. She appears generally weak, and she reports essentially that she is not really participating in terms of anything socially. She's really disengaging from any real meaningful occupation throughout the course of her day. She seems to be closing in her environment pretty much, limited to the chair that she's in. So I would really like to work on some general range of motion, some stretching, some general, or some very light exercises to get her moving, to build up her endurance, just to give her a little more confidence in terms of getting out and doing. I agree that I think we need to harness all of her supports, though. She seems to have disengaged from all of her supports, and her dependence on her daughter is growing, and I don't know how realistic that is, over the long term. So I have some concerns there. I also think that part of her pain, going back to her depression, could be psychogenic in nature, and that there may be some grief there that's exacerbating that sense of pain. And I think that we need to look carefully at that as well.
Yeah, it's always interesting, right, when we're seeing that combination or that interaction between, depression and grief and those pain complaints. I think that's real important. I agree.
I think that from what you said, if we were going to try to treat the depression a little bit differently, choosing a medication like duloxetine may help her with her pain and with her depression both. So that would be something I could provide the team with, a way to cross-wean that, to switch over from Prozac over to duloxetine as an alternative.
Okay.
Well, and she's also hopeful that once the medications are worked out, so the nausea is eliminated, ultimately she would be very open to having a meal delivery service. She was concerned about the cost, so I reassured her that any of the assistance we're talking about bringing into the home, that I'd find out what's covered and what's not covered. But just based on her recent fall and hospitalization, she'd qualify for free or very reduced meal delivery. So she was open to that. But she would like, if she has her appetite back, I think that will help overall as well with not feeling so weak, because she shared she's pretty much eating soup and crackers right now because of the nausea.
Right, right.
And
Okay.
on the short term, I really think that she could use some adaptive equipment, particularly in the bathroom where some of the falls have already occurred. I think that just having place, regardless of, if we're able to build up her strength and endurance, I think that is a good proactive approach managing things now and in the future.
Okay.
So
Go ahead, Sue.
getting back to the pain, right now she is on Norco and she's taking 8 tablets of Norco a day. I question if that might be contributing to her constipation as well. So I think it would be a good idea to try to start to back off that opioid a little bit. So a good starting point would be to separate the hydrocodone from the acetaminophen, and to provide her with some acetaminophen on a scheduled basis, which for most patients will work much better, although we usually have to convince them of that. So acetaminophen, 1 gram Q8, and then probably going with an oxycodone 2.5 milligrams that she could take 1 to 2 QID as needed, but really with trying to get her to use less of the oxycodone. We might think about some of the other non-pharmacological approaches to her pain. I really like what you're talking about with getting someone involved to help with her grief that are probably really contributing to her pain, getting some of the adaptive devices and the other things that may also help with that. But depending on where her pain is, we might be able to use either a lidocaine patch or diclofenac gel. Those are 2 other things that may help us to reduce the opioid that she's actually taking. And I do think she's been taking this now for a while, so in order for her not to withdraw, that we'll have to start to slowly back off on that opioid as well, as hopefully her pain becomes better controlled. But we want to make sure she also doesn't withdraw from the opioid.
Okay.
I think those are certainly reasonable approaches. I think it's just needing to keep as we're thinking through her pain, that she does seem to have two sources of physical pain, not only her osteoarthritis to her knees, but also the neuropathy, in her feet and lower extremities because of her diabetes. So also just thinking about how we're managing her other chronic illnesses and how those relate to her pain complaints and or her depression as well. So we probably need to think about diabetes and optimizing that treatment, maybe considering going along with those, those meals once the nausea is under control, really thinking about, do we get diabetic education in there so that she can, hopefully with all the support, really kind of reharness her ability to, navigate her chronic illnesses herself.
Yes, I absolutely agree. So certainly wasn't aware of the fact that some of her pain was neuropathic. My interview did not reveal that, and we didn't get into it too much, but with neuropathic pain, getting her sugars under better control, and the drug she's on right now is not the best one. So I think switching her over to metformin will probably help her to some degree with that, without increasing her risk of having hypoglycemia.
Okay. Well, I think we have a pretty good plan. So we can pull our pieces together and meet with her and discuss our plan with her. And thank you everybody for coming to the meeting, and I'll make that appointment with her.